Good morning and welcome. Thank you, Stryker and Jeff, for having me again this year. And this year I'll be talking about lateral approach considerations. So the lateral approach, it's not a new approach. So it dates back to the 1800s, and it wasn't until really the last 15 years with improvements in technology, such as better retractors, interbody cages, and neuromonitoring, that's become more popular. There are many advantages to the lateral approach, including not requiring an access surgeon. Also, there are many advantages compared to a PLIF or TLIF, including larger implants as well as better lordosis. The LF market is increasing every year. In 2008, about 19% of the market was the lateral approach, and last year it was almost 30%, and this trend will likely continue. So there are many steps to the lateral approach, but it starts in the clinic with pre-op counseling. So you should advise all of your patients that anterior thigh symptoms, including numbness, pain, and weakness, are normal for many patients as a side effect of the lateral approach, and usually it's transient, it's just through dilation through the psoas muscle and resolve in 6 weeks. So it's important to let patients know that, so if they have those symptoms, they'll be less concerned. In addition, you should always be prepared to convert to a TLIF or PLIF in case you deem the lateral approach not safe during surgery. Next step is to look at the X-rays as well as your MRI to determine, first of all, whether or not the approach is safe, and second of all, which side to approach, the left side or the right side. So starting with lateral X-rays, if you're considering doing an L4 or 5 lateral approach here, you can see you have high riding iliac crest, which would make it nearly impossible to do a lateral approach in this patient. On the AP, you're looking for coronal deformities. So on the convex side, it's typically easier to access the disc space because it's more open. However, at L4 or 5, it can be inaccessible due to the fact the curve, the iliac crest, will be in the way. On the concave side, you can usually access more than one level through one skin incision. However, it can be more difficult to access those disc spaces due to the collapse of the disc on the concavity, as well as those lateral spurs that often occur on the concave side. Next, after looking at the X-rays, look at the MRI. So the neurovascular considerations include laterally based vessels, as you see here. So you would not want to approach this patient from the right. You'd want to approach from the left. And if you were approaching from the left, you would not want to release the contralateral annulus for fear of a vascular injury on the contralateral side. Also look for anomalous vessels, as well as rotational deformities as seen here. And you can see this vessel on the right side, so obviously you want to approach this from the left, not the right. And transitional anatomy. So at L4 or 5 with transitional anatomy, you can have the psoas muscle be more anterior, and the lumbar plexus will then also be more anterior typically. So this is a patient you would not want to approach with a lateral approach. This is the classic Mickey Mouse sign. Other considerations, the ureters, as well as previous retroperitoneal surgery. This is a relative contraindication. And you should always have a PLIF and TLIF set available in case you deem the lateral approach not safe intraoperatively. So in terms of the room setup, anterior to the patient is a C-arm typically, as well as the monitors. The surgeon and the tech instruments, as well as the microscope, are posterior. Caudal to the patient, you have your wires, including cautery, suction, and then cranially, I usually will bring the light source. You can use a regular bed or a Jackson with a Wilson frame. I personally prefer a regular bed. The patient's placed in a lateral decubitus position, and the key here is to make sure you flex the hips and knees to 35 to 40 degrees or 45 degrees. This takes tension off the lumbar plexus as well as the psoas muscle, reducing those postoperative complications of anterior thigh symptoms. So next is to secure the patient with tape. And then you'll want the table break between the greater trochanter and the top of the iliac crest, such that when you break the bed, you'll open up the distance between the iliac crest as well as the ribs to allow better access to the disc spaces. So don't overbreak the bed. So this is a picture from my fellowship. We used to do these very large breaks in the bed. And all this does is it puts the psoas muscle and the lumbar plexus on tension, making it more difficult to retract and causing more nerve injury. So finally, after we have the patient positioned, the next step is to finalize the positioning. So what I'll do next is I'll have the C-arm come in parallel to the floor to obtain a perfect AP of the spine. So to obtain that, I want a midline spinous process and symmetrical pedicles as you see here. So to achieve that, I don't move the patient on the bed, I move the bed itself by tilting or airplaning the bed. So sometimes if the patient's kind of cattywampus on the bed or you have a very irregular curve to the spine, you may find you have to tilt the bed significantly in order to obtain that perfect AP with the C-arm parallel to the floor. In that case, you're better off to reposition the patient on the bed such that you're not tilting the bed more than 10 or 20 degrees. If the bed's like this, the patient may rotate or tilt when you're doing the surgery. That's why you want to reposition the patient. So adjust the table, not the C-arm. So to obtain the nice clean end plates, you'll have to adjust the C-arm to account for lordosis of the patient, of the spine. So next, if you take the C-arm and now be 90 degrees, it will be a perfect lateral of the spine. As you see here, linear end plates as well as superimposed pedicles and linear posterior cortex. And again, you want to adjust the table and not the C-arm. So to do this, you'll want to either break the bed or go in reverse Trendelenburg or Trendelenburg in order to get these clean end plates. You don't want to change the position of the patient on the bed itself. And ideally, you want the C-arm straight up and down such that when you have your instrument straight up and down, you know you're in line with the end plates, and it's a perfect lateral. The next step is to make an incision and then have a discussion with the anesthesiologist, try to avoid paralytics, run an EMG twitch test, and then you have free running EMG during the case. So the incision itself is dealer's choice. So when I do like a 1 or 2 level, I always do a horizontal incision. Personally, I think they heal better, and I'll do one fascial incision typically. But if you're doing a multi-level case, such as 3 or more levels, I'll typically make more of an oblique incision with more than one fascial incision. Of course, we all know the layers here. So skin, subcu fat, your muscles, transversalis fascia, retroperitoneal fat, the psoas, as well as the disc. So once you're in the retroperitoneal space, this is essential. You have to be able to palpate these key structures. So first, the medial wall of the iliac crest and the 12th rib. However, depending what level you're at, you may not be able to palpate both of those. But you should be able to palpate the transverse process as well as the lateral border of the psoas. So muscle has a very specific tactile feel to it, and this is probably one of the most important things that saved me many times. When you put your finger in there, you should be able to feel the psoas and feel those muscle fibers. If you can't, something's in the way. So you either have fat there, you have adhesions, the peritoneum, something. So you need to sweep those tissues anteriorly such that you can feel the lateral border of the psoas. Next, I'll place a guide or a probe down through the incision onto the psoas. I do not go through the psoas at this point. You want to penetrate the psoas as few times as possible. So I will target the middle and posterior third junction of the lateral disc. I'll get an X-ray. I've not gone through the psoas yet. I'll make sure I'm over this area. And then once I know I'm in the right spot, then I will advance the dilator probe onto the disc itself, and I'll confirm with fluoroscopy my position. And a few tricks there. Once I'm actually on the psoas, I'll usually put my finger in the incision and sweep anteriorly to make sure I can still feel a psoas muscle anterior to my probe or dilator. So a few tricks here. We all know the lumbar plexus runs like this. So more cranially in a lumbar spine, usually the nerves are fairly posterior. However, at 3, 4, and especially L4 or 5, the nerves can be more anterior. So I'll look at my pre-op MRI to get a sense of where the nerves may be, but usually for L4 or 5, I'll have to dock more in the middle of the disc. If I'm getting low thresholds anterior, suggesting there's nerves anterior, then you have to reposition more anterior. One of the things I'll see people do, they don't take the probe or dilator and completely remove it from the psoas. They basically kind of translate or move it anteriorly, and so all they're doing is dragging the nerves with them anteriorly, and they'll continue to have those low thresholds anteriorly. So remove the probe and dilator completely from the psoas and then reposition more anteriorly. The other mistake I'll see people do is they'll dock here, get an X-ray, realize they're caudal to the disc, and then rather than removing the probe or dilator and repositioning through the psoas, they'll just drag and just sweep up to the disc. Well, because the nerves run like this, you're likely to snag a nerve and it's going to be anterior to you. So a trick that I've just kind of discovered, which works great for me, when the nerves are more anterior, I'll sometimes dock on the body of L4, and then I'll actually sweep from there downward, and usually that'll keep the nerves posterior. So the next step here, handles should be perpendicular to the floor and in line with the disc space. So this allows the X-ray tech to get a sense of where they need to be to have that perfect AP. And then the other mistake I'll see people make sometimes is once you place your dilators and then the retractor and remove the dilators, they'll expand the retractor, and it's much, much more difficult to expand or to move a dilator this big through muscle and the nerves than it is something this big. So you don't want to expand the retractor until you have the retractor posteriorly translated to the exact position that you want it. So once I place my tube, what I'm looking at here really is to make sure the tube is obviously centered from cranial to caudal. And then beyond that, I'm just looking at the back of the body, and I'm looking at where the tube is, where it's making contact with the disc. And I want it within about 5 millimeters typically from the posterior wall of the body. And the reason for that is because I can place larger cages that way, like 22 millimeter cages, if I can get more posterior. Obviously, in certain cases, you may not be able to do that because of nerve anatomy, but in general, if I can, I'll try to place my cage, my tube right there. So other key points here, don't cut muscle. So if you cut muscle, that will obviously cause weakness. And if you cut muscle, there may be nerves in there. If neuromonitoring is not picking up or not working right, you could cut a nerve or a sensory nerve. So I don't cut muscle. I don't like to use a bovie. It can cut muscle, nerves, and it creates a lot of heat, which can cause damage to the muscles as well as the nerves. And I use limited bipolar as well. Once you have the retractor placed, then you're going to want to obtain final imaging, both an AP as well as a lateral, to make sure that the retractor is optimally placed before doing your anelotomy. This is really important because if the tube somehow or another moved on you and you haven't taken an X-ray in a little while, you may be more anterior and posterior than you actually think. So you want to confirm that placement. I typically use a microscope, especially for L4 or 5, to make sure there's no nerves in my path, depending on their anatomy. And next step would be the anelotomy, discectomy. Obviously, all these different instruments for the discectomy. For a cob, personal preference for me, I use a small cob. Just in case the retractor did move more anteriorly, I'm less likely to cut into the ALL or have any vascular or visceral injuries. In addition, I feel if it's a very concave end plate, a more narrow cob is going to do a better job of removing cartilage off the end plate than a very wide one. In addition, when you're advancing a cob, when you advance it, you should toggle ever so slightly the cob so you do not cut into the end plates. If you just push, if it's soft bone, I've done it myself many times. If you push on a soft bone, you can go into the end plates and not even realize it. If you're toggling in someone with extremely soft bone, you won't do it. You'll get that tactile feedback and it'll just ride the end plate and removing the cartilage. With pituitaries, you have to be very careful here as well, especially large pituitaries. If you're placing it in your anelotomy in the disc space and you can't see the tip of it and you're fairly anterior into your anelotomy, you could be very close to ALL and cause injury to visceral and vascular injury. So you have to be very careful with these pituitaries, especially the big ones that open up quite a bit in the disc space. And of course, curettes as well as a rasp. Other just basic carpentry techniques, don't plunge, of course, with instruments. You should always have a portion of your body on the patient. I cringe when I see somebody doing this and just pushing straight down because obviously if they all of a sudden have less resistance, they're just going to plunge right down. So you should always have a portion of your elbow, forearm, something on the patient so you don't plunge. If you are encountering resistance, it's best to use a mallet to tap your instrument. It's much more controlled than trying to just push harder. The end plate should be orthogonal to the floor. Your working instrument should be perpendicular to the floor. And for multi-level fusions, you're typically going to have to reposition the bed to keep an AP in a perfect lateral. In addition, throughout the case, even for a single level, make sure that you're not losing your perfect AP or your lateral because the patient can shift slightly on the bed. So you might have to readjust the bed to maintain an AP and lateral. So don't cut into the end plates. I personally don't like shavers and box cutters because of that. Careful with curettes and rasp. When you're At L4-5 or higher up where the ribs can be in the way, you do not want to come and approach the end plates on an angle. So if that's the case, you have to use angled instruments. You should always be in line with the end plates. You don't dig into the end plates. Preserve the ALL and use caution if you're going to release the contralateral annulus. And everybody does this, but if you do this, make sure there's no vessels on the contralateral side. And typically I'll just release it just a little bit, weaken it, and then I'll put a trial in to distract. So next, place your trial and get an AP and lateral to make sure it's appropriately placed. I try to cheat posteriorly because I like to get big cages in, and then I'll look and see how anterior it is. And if I got room anterior, I know I can go to a bigger cage because my trials typically are 18s. Then I'll put a 22 in. And if I put it in and it looks like it's filling the space, then obviously I stick with an 18. This also allows for tissue creep. So if you keep the trial in there while you're getting X-rays, it helps to allow for some tissue creep. And when you're putting in the actual implant itself, don't tap with big taps because you can break the implant. And all you have to do is once, and you don't want to do that again. So it can make for a long case. So just small taps when you're placing these in. And trial, if it's really collapsed disc space, you're going to want to trial with the actual size implant you're going to put in so you can get it in. If you under trial, which I usually do for most cases, but if it's very collapsed and you under trial, and then put in, let's say you put a trial in 8 and you put in a 10, you may actually break that implant. Use skids to help preserve the end plates. So again, if you're not coming parallel to the actual end plates, coming on an angle, a skid can help with that. So of course, the goals of the implant will be to restore your height. They're great for correcting alignment in the coronal and sagittal planes. Consider, for many patients, lordotic or even coronally tapered implants. The strongest part of the bone, of course, is the apophyseal ring. So you really want to have your implants expand and coverage that area so you don't get subsidence. So don't undersize your grafts in terms of the length of them. You want to cover that ring. And the bigger the graft, the better. Less chance for subsidence, as well as increased chance for fusion. And don't increase or put too big of a cage in terms of height, because that will cause subsidence as well as neuropraxias. In terms of closure, you want meticulous hemostasis. And so if you put a pin in or a shim, make sure you use bone wax or Surgiflow or something like that to seal it so it's not bleeding. You don't want to create a hematoma when you remove your tractor. And some surgeons will use dexamethasone as well. So in terms of the outcomes, I've been in practice for 5 years now, and so I trained at the University of Washington here in Harborview. Then I went down to San Francisco for 1 year, and for 1 year for my spine fellowship. And there I did one T-lift my whole entire year, and I did all A-lifts. So we cured tons of back pain, but that's really what my experience was. I did a lot of laterals as well. And so when I came into practice, I started doing laterals because I was fairly comfortable with that procedure because I had done them in fellowship. And then I was learning how to do T-lifts, and luckily I had Jeff as a partner, so I do all my everything through a tube, 18 millimeter tube. And so that first year and a half, I was doing quite a bit of T-lifts, even at 4-5 for single levels. I was doing T-lifts and multi-levels. I was doing L-lifts. And in the last 3.5 years, for me, I mean, I've done between L1 and L5, basically 98% of my cases now, I'll do a lateral. And most of them are L4-5, obviously, because that's where the pathology is. So I've been following these patients now for 3.5 years, and I see all my own patients. I follow them up to a year, and I really do believe in this approach because the hardware risks are so much less in terms of subsidence and other issues, even in patients with really soft bone, that I think once you get good at this and you do it, it's really hard to try to think of going back and doing it on any other technique. And I think the outcomes are good. I mean, I follow my own patients. I have not seen a lot of major neurologic issues. If I did, I wouldn't be doing it. So if you follow these tips, though, I think you can maximize your outcome. So in terms of starting off with pre-op counseling, make sure patients know the anterior thigh symptoms. Again, maybe half of patients get some type of symptoms, but even then, if you don't tell them about that before surgery, they may freak out. So let them know so they realize they have those symptoms after surgery. It's not a big deal. It's going to resolve probably within 6 weeks. Neuromonitoring is a must. You have to have that, obviously, for this approach. Even from a legal standpoint. Positioning is key, so don't overbreak the bed and flex the hips and knees. You want to relax the psoas as well as relax that lumbar plexus. And probably the most important thing above and beyond everything is just to be efficient in the OR so you can really minimize your retraction time. So when you first start doing these, obviously it takes longer. The more you do them, less and less time. So for me now, When I put the retractor in and then do the whole case and then remove the retractor, the time in with the retractor and time out is about less than 30 minutes. So if I can keep it under 30 minutes, I think that's usually pretty good. And avoid cutting muscle. Don't cut into the end plates. You, of course, want to maximize your implant size and cover that apothecial ring and meticulous hemostasis. And of course, you want to have, again, a PLIF and TLIF set available in case you find that the lateral approach is not safe intraoperatively. I've had to do that myself once or twice. So real quick, one case example. This is a 66-year-old female. She had had a bilateral decompression at 3, 4, and 4, 5, an outside surgeon. She never had relief. She saw me 3 months out, 60% back pain, 40% right buttock pain. So as you can see here, she has a spondylolisthesis at 3, 4, and 4, 5. The surgeon that did her previous surgery never had standing X-rays, so I don't think the surgeon ever knew that. He never commented on his notes. And you can see the reduce here on the MR. And she had the right buttock pain, which I thought was probably from the foraminal disc here at 4, 5. So she was 3 months out. She had had injections in the past. She was not interested in doing injections again. She never got relief from them. And it was mainly back pain. So I was like, well, let's just do physical therapy for a couple months, see how you do. So we did that for like 1 to 2 months. She came back. She wasn't any better. So what would you do at this point? So 6% buttock pain or back pain, 40% right buttock pain. She's now 5 months out from a L3-4, L4-5 decompression. So it's pretty obvious there. Okay, next slide. So if you thought surgery, what surgery did you do? ALIF, LIF, PLIF or TLIF, or lumbar disc replacement? Okay, next slide. So you can consider all of those, obviously. I mean, for me personally, since I do a lot of laterals, I'm comfortable with that procedure. I can get better lordosis. So for a TLIF, it's harder to get lordosis. So for 2 levels especially, you'd get less lordosis, at least in my hands, compared to 2-level lateral with lordotic cages. So I chose to do just a 2-level lateral inner body for her. That's it. Any questions?